Well, we've just finished a very important meeting at the Cardiometabolic Health Conference here, focusing on the management of people with type 2 diabetes, hypertension, and chronic kidney disease, focusing on newer therapeutic strategies to improve upon what we've already done in the past. With me are my good friends, Dr. Lance Sloan, nephrologist, on my left, and my other good friend, Dr. Yehuda Handelsman, who is an endocrinologist, on my right. Gentlemen, this is obviously a very interesting area. As we discussed earlier, clearly more intensive strategies to reduce blood pressure, cholesterol, and glucose, as well as lifestyle modification, can have a very important impact on the risk for kidney and cardiovascular disease progression. But we also have a lot to improve upon, both in terms of early diagnosis and, of course, improved clinical therapeutics. And so my first question would be for you, Dr. Handelsman. As you look at all of these new clinical trials, which have fortuitously demonstrated potential cardiovascular and kidney benefits with many of the newer anti-diabetic agents, what are your thoughts about this? Is it simply serendipity, or did you think that there might really be some opportunities in this regard? Again, they were all designed for safety, but now we obviously are surprised by the results.
Well, there was some surprise results that we did not anticipate early on. I think what first of all happened is with the first result with the EMPA-REG, that was the very first big result showing not just safety, but also showing superiority in terms of CV death, and later on we also saw some seemingly kidney function preservation, if not protection. But the whole discussion has changed. Up to 2-3 years ago, all the discussion was a diabetes drug, drug that manage hyperglycemia can kill, or can cause damage, or can be very bad. Now all the studies showed safety. So we know now it's safe to use them. What we also start to look is, do we get further benefit of them? I do personally think that all those drugs, in particularly the SGLT2 class and the GLP-1, have a reduction in blood pressure to various degrees, a reduction in glucose, and in other studies that we saw, like ADVANCE and ACCORD, this combination always reduced mortality, post hoc, but it reduced mortality. So this is some effect. They also may have independent effect, whether it's on the kidney or on the heart. What is clear in all of them, when we see a reduced mortality, we see improvement in kidney function. Something goes there together that we need to look forward for.
Well, let me ask Dr. Sloan this question, because you're a nephrologist like I.
He's also an endocrinologist, so he is a schizo.
Oh, all right. So he's a hybrid. Well, let me ask you this. What's impressive to me, based on your comments, is the changes in blood pressure. The reduction in weight appears to occur even in the much lower GFR patients in these clinical studies. And obviously, this is going to be an effect independent of changing glucose. It's independent from reduction of glycosuria in the case of the SGLT2s. So what might this be related to? What's the mechanism?
Well, obviously an SGLT2 inhibitor, as you know, inhibits both glucose and sodium uptake. And of course, when we talk about glucose homeostasis in the body, it involves many different mechanisms, not just the kidney. So it's certainly possible that as kidney function declines, other things that are happening in the body, such as the kidney metabolizing insulin, gluconeogenesis, partially which occurs in the kidney, all these different things can be changing where we still see effects with regards to loss of weight from calories, and because of the sodium effect, a maintenance of blood pressure, but it's possible that other things are occurring that cause us to reduce the glucose control that we see.
So I'd like to comment on that. I first would differentiate between the GLP-1 and the SGLT2. I think mechanism may be slightly different on both of those drugs where you look at them. When we're looking at the SGLT2, if you look at the lower estimated GFR, then there is no really much glucose loss. In fact, there is not much sodium loss in that group. Yet we still see the effect on both weight and we see the effect on both blood pressure. So I think there is some independent mechanism that we were not aware of with the SGLT2 inhibitors affecting those two processes of weight loss and blood pressure.
Well, I agree with you, Yehuda. My comments were really more focused on the SGLT2. I really wasn't commenting on the GLP-1 a minute ago. But it's not all just about the loss of sodium. Some of it is about the movement of sodium from one part of the nephron to another part of the nephron and hormonal things that occur in that movement of sodium from one to the other, which would potentially answer that question.
You see, I still suspect, despite all of the conversation about tubular glomerular feedback with the SGLT2s and whether or not there is glycosuria to explain this and the associated natriuresis, whether there are other mechanistic underpinnings, specifically maybe affecting vascular tone, vascular function. And like you mentioned, the GLP-1s have an entirely different mechanism of action. Again, are there vascular effects that we still need to learn about with these drugs that may be entirely independent of kidney function, independent even of blood pressure, although blood pressure is always important, independent of glycemic control that we still need to get our handle on. And again, in my presentation, I focused on one of the newer theories that there may be an effect on the sodium-hydrogen exchanger and whether or not this could be in controlling inflammatory processes. Conceivably, these drugs could work with renin-angiotensin system blockers and statins in attenuating atherosclerosis, improving renal function and vascular function. The other question, obviously, is might there be other therapeutic strategies like mineralocorticoid receptor blockers where they could be antagonistic even? So I think there's still a lot that we need to learn. I think, just saying it's an anti-inflammatory effect is kind of a grab bag, meaning, well, we really don't know, but we like what we see and we need to do more work, more or less.
So to your question, though, your comment about the vascular and the GLP-1, we do know that there is GLP-1 receptors in the vascular bed. We don't know exactly what they do. Definitely, we don't see an effect from a DPP-4 inhibitors like we see with a GLP-1 receptor agonist on that aspect. But one point I want to highlight, when we give GLP-1 receptor agonists, there's slight increase in heart rate, maybe nicely compensating reduction in blood pressure as we should anticipate. With the SGLT2 inhibitors, we have a reduction in blood pressure, there is no increased heart rate. So not only we don't see the compensated heart rate increase, we see stop of that. In my mind, there must be some kind of a sympathetic, parasympathetic effect that may be involved all the way up to maybe sudden death. I don't know.
Well, let me ask you gentlemen this, because obviously this is all very intriguing. It's all serendipitous. Let's be fair. Again, all of these trials were designed to prove safety after the Steve Nissen fiasco with rosiglitazone years ago. But now we're on to something. And I think the other issue we didn't touch on as much this morning is heart failure. And again, mechanistically you say, well, it's volume reduction, it's pressure reduction, but there might be more at the myocardial level. That being said, does this yet alter your clinical strategies in terms of how you care for patients? For example, the one patient we discussed this morning whose hemoglobin A1C had improved from 7.6 to around 7, which you very appropriately pointed out was on a very low dose of metformin, which more likely than not may have been lifestyle modification assistance as well. With all this high risk, again, kidney disease, heart disease, et cetera, dyslipidemia, do you reach for one of these newer agents preferentially and an incremental step on top of the metformin, even if you're at 7.0%?
So, unlike what I said in my discussion there, I did show the ACE guidelines. The ACE guidelines do recommend metformin, GLP-1, SGLT2, regardless of the outcome trials, as the number 1, 2, and 3 medications. I still believe in that. I also believe that it works in people with hyperglycemia. I still don't know if it works similarly in not hyperglycemia. If I have somebody with an A1C of 7, if I want to get them lower, a GLP-1 receptor agonist will get them down to a 6.5 or a 6.4, a good consideration for such a patient, and no hypoglycemia, and perhaps longer term, but we don't have the data, of cardiovascular benefit, perhaps even CHF, which with a GLP-1 receptor agonist, the whole CHF question is very murky, and I'm actually having a lecture on that tomorrow, just focusing on that CHF to say, do GLP-1 increase CHF risk or decrease CHF risk, a problem with that patient? But he had an estimated GFR of 36. Giving an SGLT2 with somebody with no background heart disease just to improve, I don't know what. I don't know if it will improve kidney function from 36. We don't know that. It's not approved for that. Glucose at that level go 0.1 at the best. So I think in this particular case, a GLP-1 may be an option going further down.
Well, Lance, let me come back to you now. You know, this whole issue of these newer medications and the opportunities are now being expanded into very large and costly clinical trials in people without diabetes. They're being done in people with heart failure. They're being done in people with chronic kidney disease. How do you feel about that, given your dual backgrounds in both nephrology and endocrinology? Is this a smart move? Might there be some opportunity in this regard?
Well, that's a great question. I'm actually believe mechanistically, as I have, that this is really, with regards to SGLT2 inhibitors, driven by hyperglycemia. And if you took a normal glycemic individual, they still will work, but of course the magnitude would be tremendously reduced. So the question is whether or not, again, in people that don't have diabetes but have CKD, whether you would have a significant effect. And nobody really knows the answer to that question. I kind of tend to believe that the diabetic patient who has, pathologically elevated blood sugars is the one who's more likely to get a significant impact versus somebody with normal glycemia. But the question has been asked, and I think it's a good question. So we're going to find out in these trials, Matt, whether or not the drugs do work in people that don't have diabetes, which of course we don't at this time.
And it's interesting that in the cardiovascular outcome trial with GLP-1 receptor agonists, we did see improvement in kidney function. I did not see independent studies on the kidney just with that particular drug. I also don't think that in normal glucose level, we will see a GLP-1 receptor agonist reduces further glucose. With an SGLT2 inhibitor, you will see a reduction in glucose in people with normal glucose, which we don't see with the others. So it's opened a totally different can of worms.
Well, let me ask you both another question with a twist on that patient who had the hemoglobin A1C improved from 7.6 to 7 with lifestyle and low-dose metformin, and their blood pressure is not at a goal level that you feel is appropriate. Would you use one of these newer anti-diabetic medications as a therapeutic strategy, not only to, in a sense, kill two birds with one stone, get to your A1C of 6.5 and get that systolic blood pressure goal down to what you feel is an appropriate goal? I'll go with you first. Yehuda, I mean, if you would, and which one would you choose? I'm just curious.
So I will first increase his metformin to 1,000 at least, if not 1,500.
But that's not going to improve his blood pressure.
Well, but it would be further improving his glucose, maybe to 6.8 or maybe to 6.7. And then I will definitely give a GLP-1 receptor agonist. I think with that, I will further bring down both glucose and to some extent the blood pressure. Would I be able to bring down just blood pressure with SGLT2? Matt, we still have non-SGLT2 blood pressure medication that we can give to this patient that may definitely bring the blood pressure further down. So I don't know if this is the right guy to give an SGLT2 as a blood pressure drug, because that's what you're saying.
Well, and I'll ask Lance this question next. Okay, let's say they're on full dose, they're type 2 diabetic with proteinuria. They still have a lot of proteinuria. Blood pressure is 140 over 90. They're on full dose losartan, 100 milligrams. They're on an appropriate dose of thiazide diuretic, 25. And let's say they're on amlodipine, 10. Would you, rather than just adding doxazosin or something else, add an SGLT2 or a GLP-1 agonist? And let's say, for the sake of conversation, the estimated GFR is 45. What would you do?
Well, that's a tough one when you throw in the estimated GFR of 45, because you certainly could, and I tend to go with what the FDA has right now, is that I initiate in people GFRs of 45 or greater with those drugs that are approved for use with a GFR of 45 or greater. I'm very biased towards the SGLT2 class. I've been involved in some way, shape, or form for 30 years since Dr. DeFranzo and L.A. Ferranini, in passing, almost in the hallway, mentioned that there's this transporter that does great things for blood sugars. So I'm really a believer it's a game changer and it has a major impact on the cardiorenal system. Now, we do know with EMPA-REG and with Canvas that they had people in those studies down to a GFR of 30. So I would probably have a tendency to use it, knowing that its blood sugar reduction at that GFR is probably not going to be great, but I still would consider it, and then probably have to add on another medication for further blood pressure control.
And that's important, because suppose we use the SGLT2, and we will get if you're lucky, 5 millimeter mercury. I don't think that much, probably not at that level. What about aldosterone blocker? I know they work less on the lower, but with aprenolone, for example, in this particular group, there was also reduction both of blood pressure and mortality. So we have to remember the whole picture. SGLT2 may add a little bit here, but you get a 4 millimeter mercury, they're still at 140, down to 136, 137. That's not enough.
Well, everything you say, Yehuda, is correct, but of course, we're kind of somewhat talking about a fantasy scenario versus clinical practice, and I can add on other drugs to get to my goal, but I believe with the data that I have that I would consider an SGLT2 inhibitor, and if you want to add spironolactone or Pleuronone on or something else after that, I think that would be reasonable too. But our goal is to, of course, reduce complications, and one of our main complications of diabetes is kidney and cardiovascular disease, really more with heart failure than with atherosclerosis.
And I would add, I'm also a big mineralocorticoid receptor blocker fan. I mean, one of my NIH grants is focused on their effect on atherosclerosis. But people are resistant to give drugs that boost serum potassium. And I would be very surprised if there would be a lot of willingness to add an MRA to somebody with a GFR of 45 who's already on full dose of a RAS blocker in the absence of any data showing benefit long-term on kidney or cardiovascular outcomes. Because let's be fair with MRAs, the data we have is in people with systolic heart failure, post-myocardial infarction with left ventricular dysfunction, kind of maybe in preserved systolic function, depending on how you view the TopCat study. And we really have no studies in chronic kidney disease. Now, in fairness, there is that new MRA being developed in Europe, and they're doing global cardiovascular studies in people with both diabetic kidney disease and cardiovascular disease, but they're not going to report out for a few years. So, but I'm a big fan of what you're saying, but I just don't think people are ready yet to jump in that direction, which is why maybe, as you would say, a GLP-1 or you would use an SGLT2, might be viewed as a safer approach to intensifying blood pressure and glucose control in these types of individuals with reduced renal function.
But we know that with the SGLT2, look, you know that I'm a huge fan of the SGLT2, and you know that I'm a huge fan of the lower estimated GFR, utilizing estimated GFR. But it was also what you suggested, get blood pressure control. From 140, and SGLT2 will give me very little. So we need to remember that. It will give me something, and it's not indicated for that either. And it's not an inexpensive drug. So we have to look at all of that. I know we have a lot of hope, but we need some more data, as you want to get it for the aldosterone blockers. We need some of those outcome data that may come out in 2-3 years.
Well, let me say two things. One is, remember that the data that we have are usually in people with SGLT2 inhibitors that have well-controlled blood pressure. With systolic blood pressures of about 130, we're seeing a reduction of 5. With blood pressures that are higher than that, we know that the reductions are greater. So you actually can potentially get the goal with the SGLT2 inhibitor. We don't have as much data as we'd like in the hypertension area, but we do know if you give it to people with higher blood pressures, you get greater drops in blood pressure. And to Dr. Weir, I would ask you a question. With the patient that you presented, what are the chances that you think that this patient wouldn't have some degree of left ventricular dysfunction and heart failure?
Well, it's hard to say. I would probably surmise more likely his left ventricular hypertrophy, because more often the overweight patient with type 2 diabetes and hypertension will probably have some pulmonary hypertension and left ventricular hypertrophy. And again, there's an evolution likely of that disease process into systolic heart failure. But let me go back to both of you and say the good news is within a year's time, we're actually going to have some outcome data from the Credence trial with canagliflozin to see in people with advanced diabetic kidney disease with clinical proteinuria effects on kidney function, blood pressure, hopefully to answer these kinds of questions. But, you know, Lance, I agree with your point. Again, you have to evaluate delta BP based on the starting point. And again, the lower you are, the less likely you are to see a net effect that's measurable, especially in a clinical trial that is designed to look at morbidity and mortality. Again, we don't take blood pressure as carefully as we should. It's much more casual, a lot more fluctuation, and the interpretability of that, I think, needs to be better verified with more sophisticated measures of blood pressure moving forward. So I think the bottom line is there is some opportunity here. I think that's the critical factor that we're most interested in. You know, I think this program that we did this morning is timely in the sense that physicians are challenged with these types of patients. And again, RAS blockade, as you discussed, has provided a 20% relative risk reduction benefit. And as I discussed, you know, global cardiovascular risk reduction efforts can do even more. But can we, again, make a much more impactful difference in these higher risk patients? And I would also say, too, going back to the point I made earlier, and that is we need to find glucose intolerance earlier in the clinical scheme of things. These people are developing blood vessel disease much earlier than we would have otherwise anticipated. And so again, earlier diagnosis, earlier anticipation of opportunities. And sadly, as we all have discussed at many meetings, there is really not going to be much effort in doing 10 and 15-year clinical trials in prediabetes just because they're so costly, so time-consuming, yet really I think that's where the action is.
We are very close. One of the companies that make an SGLT2 inhibitors actually designed a study in prediabetes, which was an outcome study, and they were going to get 8,000 patients hoping to get results by less than 5 years. And I think they made the math and they decided to drop the trial.
It's just, you know, but that's really what we need to be doing
of course.
in clinical practice. So
Yes.
whether you're a physician's assistant, a nurse practitioner, an internist, or a subspecialty person like the three of us, you know, really global cardiovascular risk management and close attention to opportunities to improve upon clinical care is very necessary moving forward.